Welcome to the Innovation Accelerator podcast, brought to you by Innovaccer, the health cloud company. We're on a mission to connect and curate the world's healthcare information to make it accessible and useful. With Innovaccer, everyone works in the service of patients like never before as one. Visit us online at innovaccer.com.
Welcome back to the Innovation Accelerator podcast. I'm your host, Steve Ambrose. On today's show, Innovaccer's Chief Medical Officer, Dr. David Nace, will be sharing an engaging conversation on some of healthcare's most critical challenges and solution opportunities with Dr. David Rhew. Dr. Rhew is the Global Chief Medical Officer and VP of Healthcare for Microsoft. He holds 6 U.S. technology patents that enable authoring, mapping, and integration of clinical decision support into electronic health records. And Dr. Rhew has been recognized as one of the 50 most influential persons in healthcare by Modern Healthcare. Now I'll hand the conversation over to Dr. Nace.
So before we get started, what I'd like to do is have you talk a little bit about your journey in healthcare. So, you're a physician like myself, went to medical school, probably had particular ambitions, and then you've been through a journey, and now you're at Microsoft. Tell us about that journey and how you got there.
Well, I guess it maybe starts in college when I was a computer science major. I actually didn't have a vision of ever applying technology in healthcare, but I liked it because I thought it was kind of fun and wanted to make video games. So it was one of the few opportunities where I started developing some skills that later on could be very helpful. As I went through my medical training, I went through the typical route that most went: medical school, residency, clinical training. But one thing I did observe, which I thought was very unusual, was the fact that there was such variation in care. Significantly, when I went to different hospitals, I'd even see it between different physicians. And I always wondered, is it actually, leading to better or worse care? Because oftentimes I didn't really have a good sense. And the more I studied it, the realization was that there was a lot of unwarranted variation. And one of the objectives that I thought was, well, maybe we can standardize care by providing the right information at the right time. And this got me down the path of evidence-based guidelines and understanding how we could organize that information into succinct ways to present to clinicians in their clinical workflow. Now, a lot of this back in the day was very paper-based and very manual. But what we started realizing was that there was an opportunity by bringing this information into electronic health records that we could automate and make this more scalable. And so this is when I started leveraging some of the computer science technology background, started working with programmers to build out a product, which essentially became a company. Then this company was acquired by Cerner, and next thing I knew, I was seeing patients half the day and then implementing EHRs the other half. And it was a first opportunity for me to get an understanding of how health information technology works. I'd say that was probably the first chapter of my career. Where I was particularly interested in was how care could be impacted outside of the hospital and clinic. This got me thinking a lot about consumers and consumer technologies and thinking that we can do more than the patient portal, perhaps maybe leveraging the mobile phone. The smartphones were pretty ubiquitous and they continue to be. And we also recognize that there's a whole other series of new devices, wearables, patches that were coming onto market. And so the thought was, could we start leveraging this whole connected health ecosystem and deliver better care? And was honored to be invited to be the Global Chief Medical Officer at Samsung, where I worked with organizations across the globe to help develop these solutions. Now, I'll say the challenges that we saw both in my first chapter in the EHR world and also in the second chapter working with consumer technologies was the same issue that we see today, which was the fact that the data was not interoperable. It wasn't something that we could actually pull together. And I was always wondering, well, why is that? And a large part of it had to do with agreement on standards. So I began focusing a lot on standards such as FHIR. And in that conversation, I realized that organizations like Microsoft were leaning very heavily into this. I joined Microsoft 3 years ago, have been working not only on the interoperability piece, but how that can be the foundational element for a technology platform that supports artificial intelligence and a variety of other ways for us to become much more effective in our clinical care.
Yeah, it's a great story, and you've covered a lot of things that we'll get into a little bit deeper. The issue of experience that people have, clinical variation, interoperability, and what does that mean for data. So let's get into some of that. I'd like to start off by talking about the fact that back when it was the Institute of Medicine, they released some early reports in 1989 and 90 that showed that we had huge amounts of safety issues and extremely expensive healthcare. What's reported now several times to be 3 times the cost of other developed countries, and yet all of our quality ratings are very low. So there's been a lot of interest in this concept of moving from fee-for-service medicine to value-based care. Can you say a little bit about what that journey is like for us as a healthcare industry, and where do you think it's going?
Well, we're on that journey. Obviously, there is a challenge in terms of incentivizing. We all know that the incentives play a huge role in terms of behaviors, but also there needs to be technologies in place that can support this. So if we think about just the steps that we've taken to move from hospital care, started then with expanding that to focusing on 30-day readmissions and 30-day mortality. I used to sit on the National Quality Forum CSAC board, and I remember as we reviewed these type of measures, which ultimately these endorsements then became pay-for-performance measures by organizations, including CMS, we found that the whole issue was that people didn't feel they had the right support. But as organizations adapted to these newer standards, we saw that 30-day readmissions, 30-day mortality became part of the standard operating procedures in terms of how we engage patients post-discharge. It's then extended to 90-day for certain bundles, and we've seen now with ACO models that we now have value-based care models that are supporting the better quality at lower cost idea. We've also seen different organizations adopt through Medicare Advantage, other programs that now are starting to head towards the path of looking at certain populations and understanding that we can prevent bad things from happening and lead to results that it can be economically beneficial for all. So I think we're now starting to see movement in the payer space and the movement towards value-based care. It certainly would be something that I think we would love to see accelerate further, because that will have a big impact in terms of how care is delivered.
You know, we just went through this 2-year period of having a pandemic, which has highlighted a number of issues in healthcare, one of which is the disparities in our delivering healthcare and the issue of health equity. And I know that there's a new model from the Center for Medicaid and Medicare Innovation come out, the ACO REACH model, which has a focus on this. How do you see that playing out, moving us forward in this concept of value-based care?
Well, I'm excited about the ACO REACH model. I think it's an opportunity for us to start recognizing that these disparities of care are occurring outside of the hospital, and they're occurring in underserved communities. And we need to do more. We need to address that. So I think that the approach is right. I would say that one thing that I would like to see incorporated into this is a greater collaboration with community-based organizations and organizations that are taking care of patients, the caregivers, the nonprofits, the groups that are trusted within these communities. Those levels of collaboration where we can enable more freer data exchange between these groups and healthcare and public health is going to be essential. I'll give you an example of some of the things that we have been involved in, which started during the pandemic, but potentially could help us serve as a model for what we could do in the future. And it relates to the fact that when we started rolling out the vaccinations in this country and throughout the world, certain populations, particularly in underserved populations, the vaccination rates remained very low. And it wasn't because of just accessibility. I think the feeling was, well, let's make it more accessible, put it into pop-up clinics and have mobile vans. A large part of it had to do with trust. And when you think about who has those trusted relationships, physicians and other healthcare providers, absolutely, but so too do the folks in the community. These are the community-based organizations, the churches, and we have to find ways that we can better partner with them.
You know, also during this period of the pandemic, we had a big movement to accessing care at home, telehealth and other things. And there's suddenly this focus coming out of the pandemic, I'm crossing my fingers here, that, real focus on innovation, right? I think everybody's hiring chief innovation officers. They're talking about doing innovation. Tell me a little bit about your perspective on the trend toward innovation and how that will start to impact kind of the experience of physicians working in healthcare and also for patients.
Yeah, absolutely. Without innovation, we're not going to be able to move forward. Innovation is in multiple different areas. There's business model innovation. There's innovations in terms of operational efficiencies. But where I've oftentimes seen some dramatic opportunities for innovation is through the use of technology implemented into these processes that allow us to become much more effective. Everything from transforming the experience that we see with clinicians and the patients. The counter that one would have is traditionally problematic in the sense that you have to then spend time to document and put the information into the EHR. There's a significant amount of information that you have to then ingest and analyze after the visit, whether it be through emails and going through that large list of emails after your encounter, and then handling all the insurance claims afterwards. So what we're finding is that clinicians, a big part of the reason why they're burned out and maybe dissatisfied with their position has to do with that we've added a lot of administrative things onto their plates. We can use artificial intelligence and machine learning, natural language processing to convert those into things that processes that are more seamless, that don't require as much manual data entry. We will have improved the experience for not only the clinicians, but the patients. And so these are examples of innovations that are not only just ideas, but actually are things that we are seeing being implemented today.
Now, I know that at Microsoft, you made this acquisition of Nuance, and Nuance does some very interesting things to help with that experience in the exam room itself. So can you say a little bit about where you are with leveraging that acquisition and thinking about this concept of active listening?
Yes, I'll start with the actual innovation in the clinical environment. And that was something that we had been working on for some time, as had Nuance. And it's called Ambient Clinical Intelligence, or ACI. Imagine you're the physician, I'm the patient, we're having a conversation. And typically what will happen is, because of the fact that you've got so many things going on, you're going to probably turn your back to me and start entering all the documentation into the EHR as we're talking. Now imagine a scenario where there's technology in the background that I've been informed about, so I know what's happening, but it's listening. It's actually capturing from voice to text our conversation, understanding who's saying what, and then also mapping those terms to concepts with back-end to terminology so that we can organize them into clinical notes. And that clinical note then can be reviewed by the clinician, push a button, and upload it into the EHR. It's something that we've already seen saves the clinician about 50% of the time and has a dramatic impact on clinician burnout and impact on patient experience. I think what we're now starting to recognize is that this type of technology is something that could transform the way that healthcare is delivered. Microsoft and Nuance have been working as partners on this, but given the tight alignment of this, as well as a variety of other areas where we've been focusing on artificial intelligence in healthcare integrated into clinical workflows, we thought it would be a perfect partnership that we could extend further if they became part of Microsoft. So we acquired Nuance, I guess it was this past year. And what we've now found is that there's been tremendous new opportunities for us to be able to start leveraging the Nuance technologies combined with the Microsoft technologies.
Yeah, it's a great story. There's also a lot of talk in the industry about the concept of the patient experience. And as you know, Microsoft, as well as here at Innovaccer, we serve providers and payers and life science organizations. And this concept of the digital front door, how does that play in?
Well, one of the things that you mentioned, Innovaccer. Innovaccer is one of our close partners. Innovaccer is essential in terms of making sure that data flows into the clinical workflows and that allows us to be able to have a more seamless experience. Patients oftentimes are unaware of a lot of these data issues. What they're interested in is that experience that they have with the clinician. And a lot of times that experience can be problematic, everything from scheduling, registration, that finding ways that the conversation is captured and the doctor's not, or the clinician is not paying attention to them. So this is where the technology can be applied to help us with that data acquisition and the movement of the data into the different systems. I'll give you a couple of examples of things that I think are particularly interesting. When you have a conversation with a clinician, we know that information needs to be then brought into the medical record, but it also could potentially be used to help inform both the clinician and the patient of opportunities. We've been using chatbots as a means to be able to provide information that can be synthesized rather quickly and let us know about certain programs. So for instance, if we're having a conversation and it turns out that I've got an issue of, let's say, cancer, boy, it would be great to know that I'm eligible for certain clinical trials And rather than waiting later on to see, having someone go through the process of manually determining my eligibility for it, running through that algorithm and letting both the clinician and the patient know. I mean, this is something that we have built already through the AI-based chatbots, clinical trials matching. This is something that we saw during the pandemic when patients started having questions about, do I have COVID? Where do I need to go? All that information can be provided in real time. So we're starting to see these technologies all integrated into not only the clinical workflows, but also into the patient experience.
You brought up early in your career the interest in this issue of variations in care. And as we know, that term was often unwarranted variation in care as we began to examine it a little bit more. And you've brought up this issue of data and technology several times. So what has been the challenge with bringing the data together from different sources, and where are we at as an industry in resolving it?
Well, I guess the first challenge is that we have a lot of silos. The data itself is oftentimes in different formats, so we need to agree on certain standards. FHIR is actually a great interoperability transport standard that allows us to be able to move data. And I feel like we're making significant strides towards getting FHIR adopted across the entire ecosystem and also covering multiple things, even beyond medical record and claims data sets. There are now FHIR standards for DICOM, for Internet of Medical Things, and where there's work also being done in social determinants. So I think we're now starting to see standards be a big part of this. But the other thing is that there's so much data in unstructured data, unstructured forms such as voice, text, images, video. And if all of that information can also be converted into structured formats, again, leveraging these interoperability standards, we now have a much better understanding of the individual, where they are on their journey, and which will allow us to be able to apply artificial intelligence and all the different algorithms that are being built on these different data sets to become much more useful.
There's a lot of interest in this issue of the social determinants of care, which I often break down to social, environmental, and economic issues that drive the health outcomes in a much greater way than traditional medicine does. When you talk about data, what about other sources of data? Things like credit scores, etc. My friend David Nace at the College of Population Health once remarked the two biggest predictors of health outcome were zip code and credit score. Say a little bit more about the complicated approach to thinking about these other sources of data and where are we at today?
That's absolutely right. If we want to address the issues that people face today, we can't just simply assume it's about, I'm prescribing you a medication and you need to take it. We have to understand the reasons why people will and will not take it. There's a significant issue around access to care, being able to provide the information that a person needs to be able to know what to do when. So that's one aspect. There's an element of being affordability, being able to afford medications and treatments. And then there's this whole other spectrum of things that relate to your diet and access to food and the ability for us to be able to address the fact that we may not put health as a top priority, because putting food on the plates of your family is maybe the number one priority, and then your health kind of comes somewhere down that list. And when health isn't your top priority because you've got all these other things you're focused on, it's very difficult for us to be able to solve these problems, specifically when you have patients with multiple comorbidities and advanced diseases. So I think what we need to start doing is looking at how can we first understand the issues, and then are there certain ways that we can help address them? And that's one of the really exciting things is we've been thinking about artificial intelligence. A lot of times when I'll just use a simple example, making a phone call to set up an appointment. Typically, there's one thing that happens. I call, they look to see if it's available, and we're done. Move on to the next call. Well, there's a missed opportunity there. What if I live 60 miles away? What if I've missed my last 4 appointments? What if there is raining on that day? These are all factors that probably indicate that I will likely miss that appointment or be late. Wouldn't it be great if we actually had programs that could address that? Because we knew that individuals that are no-shows for certain types of, particularly because they're higher risk or perhaps is undergoing a procedure, has a direct economic impact for this organization. We should bring that information together and let the individual know that, hey, it looks like it's going to be a rainy day. It looks like you live 60 miles away. We have a ride service. We can pick you up and we're going to let you know about this. That's the type of we'll call it concierge service, but it also is addressing the needs that people have, because we know that without addressing those needs, it's unlikely that they'll be able to continue to maintain their health. And we sometimes need to go above and beyond simply just making it accessible.
I love the emphasis here on the experience of care that the patient would have. So I think all of us, even you and I, as physicians, often have struggles with navigating the healthcare system, getting one provider to talk to another one, getting the right information, having the data in one place for our friends or relatives, etc. You mentioned this concept of interoperability, being able to have data flow between an ecosystem is the term you used earlier. I love that. Do you think the TEFCA framework and the work that came out of the Century 21 will allow payers and providers and other healthcare entities, maybe even, as you mentioned, consumer-based organizations, do you think that will resolve this in the short term, or is this a long ways off?
I think part of the confusion is that when you think of it, you immediately go into a mode of thinking about what you see in movies and TV, and you think of a machine that has the capabilities to truly understand, maybe even feel. We're not quite there yet, but what we do know is that with sophisticated learning algorithms, that we can automate processes that oftentimes are very manual and take a lot of time. And that is something that AI is particularly good at. So when we have data sets that are available that allow us to be able to pull the data together, understand the different context behind it, apply these models, and then learn from them, it gives us an opportunity to be able to transform the way that we interact with people and the way that we can operate. And that's what artificial intelligence is. It's really augmenting the individual's own capabilities through the machine and through the computer. What I have seen as the next step is we're building a lot of amazing algorithms. We certainly need to recognize, is the algorithm that we just built representative of the population that we intend to deploy this in? And it reminds me a lot of when you think of clinical trials. If I run a clinical trial on a small group of patients and I say, wow, we got some amazing results, and I'm going to now run this across the entire nation, it may be that we didn't test it in that population, and perhaps we're going to get some different results. So we have to not only assess, but we have to, or assess before we roll it out, but we also have to assess after we've implemented it. We have to determine, is it doing what it was designed to do? And then we have to look for drift. Is there actually going to be a change over time in terms of how this gets implemented? A lot of things happen, in terms of how newer technologies come out, newer standards, newer ways of approaching things. So we need to stay on top of the AI. So AI is not just simply build an algorithm and deploy it, but it's going to be an entire life cycle of things that organizations are going to need to start thinking about as they start thinking about how AI can be incorporated into their clinical workflows.
I really like the concept you said about automating tasks. So, we hear this all the time. We went through this Great Recession. We did the HITECH Act. We spent $60 billion implementing electronic health records, as you pointed out, that often don't talk to each other. And the physician, and I hear this from my colleagues all the time, they're tired of doing computer entry, taking work home, doing follow-up work. They feel like they're administrators now. And patients often say, well, my doctor doesn't talk to me. He's always busy typing in the computer. What are some tasks that can be automated to free this up? And how can it really impact the physician's experience and go back to having the joy of practicing medicine?
So we talked about ambient clinical intelligence as being one. I'll give you another example. When I go home, I oftentimes find, this is when I used to see patients, I'd get about 200 so emails. Some of those were emails that, in the end, I am like near the end of my day. I'm pretty tired. I'm trying to sort through all of them. May unfortunately be that the last email was the most critical. So having an understanding of which emails are things that I need to respond to, with immediately, understanding what are the things that perhaps others can take advantage of. And so leveraging natural language processing, searching through that, sort of like when you look into your inbox and, a lot of times it's organized into things like social or promotions and, a variety of other categories. Now imagine it being organized into, this is related to the appointment scheduling. This is related to medication side effects or refills. This is related to a particular type of maybe social activity, like happy birthday, These are the things that are essential for us to know. How do we triage and prioritize? And if that could be applied, and it is currently being applied right now, several organizations are starting to look at how these technologies can be used to automate this type of process. We're going to have a better user experience.
Yeah, you mentioned the lack of standards historically around data, the evolution that you've made with this wonderful Fire API server that Microsoft has offered. Clearly, we're working with you in partnership and populating that Fire server. I was reviewing our clients. About only 4% are currently using Fire standards, but we expect that to move forward very quickly. What are some things we can really accelerate the adoption of Fire with?
Well, certainly the government and the policies around enforcement are going to be a big factor. But I also think that as people start recognizing the value that we can get, so there's different applications that we're going to start looking at how Fire can be activated to enable a lot of these use cases that I'm talking about. Because at the end of the day, all the AI can only work when the data flows into it seamlessly and it flows out of it. And it has to go into clinical workflows. That's where Fire is going to be of tremendous value, allowing us to be able to take full advantage of all the AI that we're building, because that's going to allow us to be able to get excited about adopting this because it's going to lead to real value. So interoperability is a vehicle for us to be able to generate the things that we are interested in, which is better experiences, lower cost, greater access to care. We need to do that by focusing on the outcomes, and then we'll realize to make that possible, interoperability will be our vehicle.
Yeah, interoperability is a great concept, and it's all about data and bringing data together, making sense, and building out a common record, and then that can populate all these wonderful algorithms and AI that you've discussed. You said a little bit about other partnerships as well, partnerships with life science companies and pharma. There's a lot of interest in this concept of real-world evidence, virtual clinical trials. Can you tell us a little bit about what your experience has been at Microsoft with looking at these opportunities for partnership?
Yeah, so partnerships come in all different shapes and sizes. I'll tell you about one of the largest partnerships that we have. It's with a group that has organized data across, I think it's maybe like 18 or 20 of the largest health systems in the United States, representing about 17% of all the clinical data, all de-identified. It's called Truveta, and it's something that we have found that has tremendous opportunity. We want to think about back to the AI algorithms. They need to validate and vet this against larger data sets. Well, it doesn't get much larger than this in terms of your ability to validate. So I think that these type of collaborations and allowing for us to be able to participate and help, whether they be pharma, life sciences, or startup companies, or mid-sized companies, or healthcare organizations with their AI, and answer questions that they may have on populations that they're serving, this is going to be of great value. We also recognize that there are a lot of different ways that we can help support our partners in these different areas. And a lot of times that requires us to build through partners solutions. And again, what we've found is that when we start looking at how partners are building their solutions, it oftentimes starts with the fact that there's a certain amount of infrastructure that needs to be there, or data needs to be secured. We need to protect it against cyber attacks. We need to start building in interoperability. And that is something that Microsoft has out of the box. With the Microsoft Cloud for Healthcare, our ability to be able to develop or to offer up a platform that supports the needs for safety, security, privacy, but also has a stack of technologies that are very healthcare specific, including the Healthcare Fire APIs that you just mentioned, as well as a variety of other types of tools. That's going to allow our partners to become successful in rapidly building and scaling out their processes so they can deliver on the solutions for these different industries.
David, you've mentioned life science companies before, and there's a lot of interest in doing this idea of real-world evidence and research by using data from multiple sources and aggregating it. And there's a lot of concern about making sure that data not only is private and secure, but that it's also de-identified in doing that sort of research. What are the opportunities in the industry for doing this real-world evidence, and where are we at today?
Yeah, I think there's several opportunities. First and foremost, oftentimes we find that data sets need to be validated against larger data sets. And working in collaboration with one of our partners who has pulled together data sets from, I think it was 18 or 20 of the largest health systems in the United States, The group is called Truveta, representing about 16 or 17% of all U.S. clinical data. It's all de-identified, and it's information that allows us to be able to then vet algorithms against that. Now, we also find that there's opportunities where we might be able to then take information and bring it into an environment, a confidential environment that supports the organizations to be able to validate those algorithms against the larger data set, but at the same time preserve IP and data security. So above and beyond de-identification, zero trust frameworks and the ability for us to be able to leverage confidential compute environments is another way that we're seeing that some organizations have found to be valuable. So there's a lot of different ways that we can enable data sharing, allow for data to be validated against different data sets, and do it in ways that are involving both de-identification as well as going on and adding that level of confidential compute.
It makes a lot of sense in terms of sharing data and keeping it private and secure. This real world evidence, we often talked about this gap, this time gap from when evidence is discovered to where it's implemented in clinical care. Real world evidence will play a role in helping to close that gap.
Absolutely. And I think we have to start recognizing that it's not just about capturing the data and being able to analyze it, but as you said, closing the gap in terms of time. It can't be that it takes a year or many months before we figure out the fact that certain algorithms are not working as designed. We really should do that as close to real time as possible. So that means that we need to start thinking about how do we build in interoperability again into these systems so that outcomes are being captured immediately and being brought to the surface and comparing it against expected outcomes. And that allows us to be able to then determine if and when we need to deviate or adjust the course by allowing us to reassess whether the algorithms are designed in a way that's addressing the current needs. That, to me, is representative of sort of the bigger issue. If I like to sometimes think about AI and the amount of AI that's being generated as building out a capability to send planes into the air. But we need air traffic control. We need an ability for us to be able to know what algorithms are on the ground, what are in the air, what need to be brought down, when do they need to be brought down, and we need to have those communications as close to real time as possible.
This brings us back to some of your early interests in clinical decision support and addressing many things, not just innovations and insights that come from real world evidence, but even closing the gap on that variation in care. Physicians often complain about having too many alerts and too many pop-ups. I know when I drive a car, it's wonderful to have Waze tell me there's an accident ahead, turn right, and I'll save 13 minutes. What are some of the opportunities to really bring forward these clinical insights, actionable insights to the physician, to the patient, to other stakeholders, and how might that be coordinated?
So I think we had the right idea with clinical decision support, right information at the right time for the right individual so that they could act on it and be able to do something. But the reality is a lot of the information that we're presenting back to them is either stuff that they already know, will make no difference, or is noise. And what we have to really understand is, do we truly understand the scenario? Is it something that we have learned that this is something that's not necessary? You ever walk into an ICU and you hear all that beeping, every machine, and they're constantly turning it off? I mean, it's beeping for a reason, because there was certainly an alert that needed to be presented. But we need to figure out ways to make this decision support smarter. We need to understand more inputs than just simply one parameter. That means looking across the board. And again, back to what we talked about before, interoperability, different data sets, pulling it all together, applying AI on top of it, making decisions support smarter, more sensitive and specific, and ultimately more accurate.
David, this has been a great conversation. I do want to ask you one last question to sort of wrap this up. There's a lot of problems we talked about in the industry. If you were able to just snap your fingers and solve one single problem today, what would it be?
Well, we've talked a lot about interoperability and the benefits that we have. So many barriers today towards achieving that goal. We can envision a state where all of that information could be seamlessly brought together and individuals could have access to that, the so-called longitudinal patient record that allowed them to be able to share that information to whom they wanted to share that with, much like we envision and we see today in the financial industry where you can go to any bank around the world and be able to share and pull information. That's how we would love to have healthcare. Healthcare can be made more interoperable. We need to leverage the standards. The technologies today allow us to be able to move that towards that direction.
David, you reminded me I'm about ready to head out on my first vacation in a year. I'm going to Greece, and I don't worry at all about finding an ATM on any corner and using the same access card that I use today here. In healthcare, that would be a wonderful solution to have. So,
and God forbid, if you were to have a need for a medical emergency, for you to be able to present that information to that doctor in Greece and have them know exactly what you need to know or they need to know about your prior history, your medications, your allergies. That would also be a fantastic security blanket.
We did it in banking. Let's do it in healthcare.
That's right.
Yeah. Dr. Rhew, it's certainly been a privilege and a pleasure speaking with you. Thanks for being on the show today.
It's been my pleasure. Thank you for having me.
Our thanks to today's show guests, Dr. David Rhew and Dr. David Nace, for their time, insights, and discussion. And for our listeners, don't forget to check the show notes for links to resources and contact information related to today's show. And stay tuned to the Innovation Accelerator podcast for more shows covering the healthcare IT topics that you care about. For more information on this and other healthcare IT topics, please visit Innovaccer.com. I'm Steve Ambrose, wishing you a great day.
You've been listening to the Innovation Accelerator podcast, brought to you by Innovaccer, the health cloud company. Don't forget to check the show notes for links to related resources and other information. And stay tuned to the Innovation Accelerator podcast for more programs about the healthcare IT topics you care about. Accelerate your transformation and build the future of health on the Innovaccer Health Cloud. For more information, please visit Innovaccer.com.